Program Studi Doktor Ilmu Kedokteran Gigi Fakultas Kedokteran Gigi Universitas Indonesia didirikan sejak tahun 1993. Adapun visinya adalah menjadi pusat pendidikan doktor ilmu kedokteran gigi yang membentuk sumber daya manusia berintegritas tinggi, berwawasan luas, serta mampu berperan serta aktif dalam percaturan ilmiah global menuju unggulan di Asia Tenggara. Program Studi Doktor Ilmu Kedokteran Gigi melaksanakan pendidikan berbasis kompetensi melalui metode pembelajaran aktif yang mempersiapkan peserta didik agar mampu menemukan, mengembangkan, dan menciptakan karya baru di bidang ilmu pengetahuan dan teknologi kedokteran gigi melalui penelitian yang bermanfaat serta mempublikasikan hasil penelitian tersebut dalam jurnal nasional dan internasional terakreditasi untuk kepentingan perkembangan ilmu dan teknologi serta kesejahteraan umat manusia. Program Studi Doktor Ilmu Kedokteran Gigi Fakultas Kedokteran Gigi Universitas Indonesia memiliki fasilitas yang memadai seperti ruang diskusi, perpustakaan, laboratorium oral biologi, serta laboratorium dental material yang dilengkapi dengan alat-alat dengan teknologi terkini yang dapat menunjang berbagai proses pembelajaran serta penelitian mahasiswa.
Program Doktor Ilmu Kedokteran Gigi Fakultas Kedokteran Gigi Universitas Indonesia memiliki dua jalur penerimaan, yaitu jalur kuliah dan jalur riset. Program Studi Doktor Ilmu Kedokteran Gigi Fakultas Kedokteran Gigi Universitas Indonesia terus berkomitmen untuk menghasilkan lulusan yang berintegritas tinggi dan tanggap terhadap perkembangan ilmu pengetahuan dan teknologi, serta mampu mengembangkan ilmu pengetahuan dan teknologi tersebut dengan menjadi peneliti yang handal berdasarkan konsep keterbaruan ilmu pengetahuan.
Program Studi Doktor Ilmu Kedokteran Gigi Fakultas Kedokteran Gigi Universitas Indonesia memiliki staf pengajar bergelar guru besar dan doktor yang berkualitas dan berpengalaman pada kegiatan ilmiah dan penelitian serta publikasi baik di tingkat nasional maupun internasional.
Program Studi Doktor mengajarkan saya untuk berpikir sistematis, mencari ide-ide kreatif untuk riset kedokteran gigi.
Saya adalah salah satu orang yang beruntung mendapatkan kesempatan melanjutkan pendidikan di Program Studi Doktor Ilmu Kedokteran Gigi FKGUI. Pengetahuan baru yang saya dapatkan benar-benar membuka peluang untuk terus maju. Program Studi Doktor Ilmu Kedokteran Gigi FKGUI memiliki pengajar yang kompeten, sarana, fasilitas belajar, dan riset yang memadai, serta networking yang luas. Bangga menjadi lulusan dari universitas terbaik di Indonesia.
Pada bidang penelitian, Program Studi Doktor Ilmu Kedokteran Gigi bekerja sama dengan institusi pendidikan di dalam maupun luar negeri, bidang industri, dan pemerintah daerah serta pusat-pusat studi atau kajian di lingkungan universitas. Selain kegiatan akademik, Program Studi Doktor Ilmu Kedokteran Gigi Fakultas Kedokteran Gigi Universitas Indonesia juga memfasilitasi mahasiswa dengan kegiatan non-akademis seperti olahraga, seni, dan gathering yang juga bertujuan untuk meningkatkan soft skill mahasiswa. Pada tahun 2020, Program Studi Doktor Ilmu Kedokteran Gigi telah menghasilkan 117 lulusan doktor yang aktif sebagai peneliti, sebagai staf pengajar di beberapa perguruan tinggi negeri dan swasta, maupun sebagai pemangku jabatan di institusi kesehatan.
Program Studi Doktor Ilmu Kedokteran Gigi FKGUI memberikan layanan pendidikan yang bermutu dan berstandar nasional melalui dua jalur, yaitu jalur kuliah dan riset serta jalur riset. Sebagai dekan sekaligus staf pengajar, saya yakin program studi doktor mampu melahirkan lulusan doktor yang unggul, profesional, serta mampu bersaing secara global. Saya dukung program studi doktor untuk terus maju mewujudkan FKGUI menuju unggulan di Asia Tenggara.
Banyak sekali ilmu yang saya dapatkan selama menjadi mahasiswa program studi Doktor Ilmu Kedokteran Gigi Fakultas Kedokteran Gigi Universitas Indonesia. Fasilitasnya lengkap dan staf pengajarnya ahli, berkualitas, dan luar biasa. Sangat membantu saya dalam proses pembelajaran serta penelitian.
Saya adalah salah satu orang yang beruntung dapat melanjutkan pendidikan di program studi Doktor Ilmu Kedokteran Gigi FKG UI. Pengetahuan baru yang diberikan pada saya benar-benar membuka cakrawala baru bagi saya. Suasana akademik yang kondusif membuat saya terus semangat belajar. Saya bangga menjadi alumni S3 FKG UI.
Saya yakin lulusan program studi doktor Fakultas Kedokteran Gigi Universitas Indonesia memiliki daya saing tinggi dan tanggap terhadap ilmu pengetahuan dan teknologi.
Distinguished guests, good afternoon, and welcome to Open Doctorate Thesis Defense of Sariesendy, DDS Orthodontic Consultant. Soon, the Open Doctorate Thesis Defense will begin. Please mute your microphone. Thank you. The Open Doctorate Thesis Defense to obtain doctoral degree in dental science program now begins.
Distinguished guests, allow me as the chairman to start this Open Doctorate Thesis Defense. The Open Doctorate Thesis Defense now officially begins. Doctorate candidate, the Board of Examiner will ask questions related to your thesis titled Post-Treatment Changes in the Mandibular Arch in Patient with Unilateral Cleft Lip and Palate, Study in Cleft Lip and Palate Craniofacial Center, Radboud University Medical Center. Professor Dr. Beni S. Latif, TDS Oral Surgery and Maxillofacial Consultant, we invite you as the promoter to start the examination.
Doctoral candidate, we invite you to read the summary of your thesis within 15 minutes.
The Honorable Professor Dr. Beni Sharif Shah Latif, DDS Oral Surgery Maxillofacial Consultant, allow me to read the summary of my thesis manuscripts as follows. Unilateral cleft lip and palate is one of the most common birth defects. Most unilateral cleft lip, alveolus, and palate, UCLAP, are non-syndromic with a prevalence of 1.37 per 1,000 births in low and middle income countries. Mossy and Model in 2012 estimated the prevalence per 1,000 births in Southeast Asia being 1.08. Also, it has been found that the prevalence in cleft lip and palate CLP in males is higher than in females. Treatment of these birth defects requires a comprehensive interdisciplinary approach, and follow-up of the patients is also an integral part of the team duties to assess treatment outcomes within a team and to compare the results with other centers in order to improve cleft center. Most orthodontic studies concentrate on dental arch relationships and changes in the maxillary arch. To our knowledge, no studies are available in the literature that describe the concomitant changes in the mandibular arch. It is well known that the maxillary arch, and in particular the transverse dimension in patients with a cleft palate, is prone to changes after treatment, especially because a considerable amount of expansion is needed during the orthodontic treatment to overcome the constrictive effect of palatal scar tissue. It may be possible that the mandibular arch will adapt at least partly to post-treatment changes in the maxillary arch, but it may also be possible that the mandibular arch remains stable. This would result in disturbance of the transverse relationship between the arches. Several factors could influence mandibular arch changes and inter-arch transverse relationship after treatment, such as sex and age at the end of treatment, orthodontic opening or closing of the space of a missing maxillary later incisor, extractions in the mandibular arch, expansion of the maxillary arch in relation to secondary bone grafting, and inter-arch relationship as represented by the Gosselin yardstick at the end of treatment. These factors may predispose to changes in the dental arches for which the operator should anticipate with the orthodontic retention appliances. The aim of this study was to determine long-term changes in transverse mandibular arch dimensions and to determine inter-arch-transverse relationship in patients with a complete non-syndromic unilateral cleft lip alveolus and palate, CUCLAP, until 5 years post-treatment. Risk factors that could affect the stability of the transverse mandibular arch dimensions and the transversal inter-arch relationship were also studied. This is a retrospective longitudinal study in patients with a non-syndromic CUCLAP. The sample size was 75, collected consecutively directly after, 2 years after, and 5 years after treatment, born between 1st January 1983 to 31st December 1992, and treated at the Cleft Lip and Palate Craniofacial Center, Radboud University Medical Center, Nijmegen, the Netherlands. The present study shows that the mandibular arch does change after the treatment has finished. The mandibular intercanine distance did not change significantly over time, as could be expected, because 85.3% of the patients had a mandibular canine to canine retainer bonded to all anterior teeth. The interpremolar distances diminished significantly over the 5-year study period with about 1 millimeter. The first and second molar distances increased slightly, but this was only significant for the second molars. The latter can be explained by uprighting of the mandibular molars buccally from a more lingually oriented crown torr, which occurs with age in untreated dentitions, leading to an increase of the intermolar distance. However, it should be noticed that changes of the intermolar distance were minor, which is consistent with the earlier longitudinal studies. In our study, the interpremolar distances diminished slightly, while studies on untreated subjects have shown that interpremolar distances in the mandible reach stability between 16 and 31 years of age and remain stable from 13 to 60 years of age. These changes in the interpremolar distances might be explained as an adaptation to changes in the maxillary dental arch in CUCLAP, which is subject to the ongoing constrictive effect of palatal scar tissue, as has been shown in animal experience, in which animals were followed into adulthood. In contrast to the lack of data of mandibular arch dimension in patients with orofacial clefts, there are a few studies that reported post-treatment changes of the occlusion and maxillary arch dimensions. Murchison and Paulin evaluated occlusion and maxillary arch dimensions from 19 to 25 years of age with the MHB index and found that the deteriorations were significant in all 3 segments. Sam Ronin and Abelholm did a long-term study on antero-posterior relationship using Goston yardstick and observed that from 16 to 20 years of age in 30% of patients, the Goston score worsened. The changes were partly due to continuous mandibular growth. Ismaniati from Universitas Indonesia also reported in her PhD thesis in 2016 that the Gosson yardstick significantly worsened over time, while some transverse maxillary distances diminished. A series of studies from Boro in Brazil in a convenience UCLP sample reported on short-term changes, primarily on the maxillary dental arch in relation to rehabilitation with a dental implant or anterior fixed bridge work. This study showed that the maxillary arch was not stable until 1 year post-treatment, regardless of the type of prosthetic rehabilitation. In our research, the MHB scores deteriorated up to 4 points for the total score, which means there is an increase in the number of teeth in crossbite. The deteriorations happen in the inter-arch relationship, yet the mandibular arch showed only minor changes of the transverse dimensions. It means that the mandibular arch did not adapt completely to the changes in the maxillary arch dimensions, because if it did, the MHB score would have remained the same. We also studied factors which may influence the changes of the mandibular arch and the MHB score after treatment. We did not find a clean pattern for the effect of age at the end of treatment, sex, maxillary expansion before bone grafting, space closure for missing maxillary lateral, mandibular premolar absence, or Gosson score at the end of treatment on the mandibular transverse dimension over the 5-year follow-up. For the interarch relationship, we found that age at the end of treatment, space closure for missing maxillary lateral incisor, and Gosselin at the end of treatment seem to have an effect, especially in the first 2 years after treatment. Patients who were younger at the end of treatment tended to have more changes, probably because of remaining growth. Therefore, it should be taken into account that there may be a risk of post-treatment changes if we finish treatment while growth has not ceased. We also found that the post-treatment changes were less if patients had a lower Gosselin score at the end of treatment, which stands for a better sagittal-jaw relationship. This is encouraging to know because it helps us to know, and we can inform the patients what to expect of their treatment stability. This study shows that changes after treatment occurred especially during the first 2 years after treatment. Therefore, clinicians should anticipate with their retention protocols. It is recommended to use, besides the bonded retainers, a Holey retainer during the night to maintain the transverse dimension after treatment. Due to the long-term palatal scar tissue, the patient must be advised to use the Holey retainer lifelong. It was also shown that patients who had a good Gosselin score at the end of treatment maintained a better transverse dental arch relationship over time. Therefore, it pays off to strive for the lowest Gosselin score at the end of treatment. Although this is not always possible due to the individual growth pattern of the patient. A common feature in the patients with CUCLAP is a genesis of the maxillary lateral incisor at the cleft side. In this study, we found that if the space of missing maxillary lateral was closed, the interarch deterioration in the first 2 years after treatment was larger compared to opening the space for a lateral incisor. This may be explained by the fact that closing the space narrows the maxillary dental arch, facilitating a crossbite tendency, which will be reflected in the deterioration of the MHP index. This raises the questions whether it would be wise to open the space and replace the missing maxillary lateral with a Maryland bridge or dental implant. Furthermore, in many cases, bone grafting is still necessary before dental implant placement because bone volume loss occurs after secondary bone grafting when no tooth has erupted or placed orthodontically in the area. Also, peri-implant soft tissues are aesthetically less pleasing in patients who did not receive additional bone augmentation, as the implant cannot be placed in its optimal position due to insufficient bone volume. However, so far there are no long-term studies of dental implants in patients with clefts comparing therapies, risk, and outcome. There is still a lack of study into long-term changes in patients with CUCLAP, not only regarding the dental arch relationship and facial changes, but also regarding other aspects of treatment outcome. The adult individual with a treated cleft deserves more attention in cleft research. This study is performed in a large sample of consecutive patients observed for 5 years after treatment. There are hardly any studies about stability after treatment focusing on the mandibular arch. The loss to follow-up was low, less than 10%, and the patients were treated from birth on in one center with the same protocols by 2 experienced surgeons, which is important to notice, as it has been proven that the skills of the surgeon play an important role in the final result. However, the present study is a retrospective study and performed in one center, which means the results are valid for Caucasians and for the treatment protocol which is employed in the center. To conclude, in patients with CUCLAP, changes occurred in the mandibular arch expressed as changes in the transverse dimensions and interarch relationship measured by the MHP index. A younger age at the end of treatment, space closure for a missing maxillary lateral incisor, and a higher Gosselin score at the end of treatment negatively influence the interarch transverse deterioration, especially in the first 2 years after treatment. For the transverse dimensional changes in the mandibular arch, such influencing factors could not be determined. Based on this study, we suggest that studies in adult patients with clefts should be performed since there are hardly any. Therefore, there's still a gap of knowledge on performance of cleft lip and palate treatment in the long term. Adult patients with rehabilitated CLP deserve more attention. Cleft and palate centers should include routine long-term follow-up examinations in their treatment protocol with standardized documentation at fixed time points. The global cleft community should agree on a minimum core outcome set of documentation to enable the inter-center comparison. Frequent changes on treatment protocols in centers should be avoided because it will make research of the treatment outcome difficult to do. It is advised to change treatment protocols only based on scientific evidence and in agreement with all team members. Treatment records should be available and stored in digital format, for it will be easier to perform collaborative research, not only within a center, but also between centers. Thank you very much.
Mrs. Chairman, the floor is yours.
Yeah. Before the examination starts, we advise that its examiner asks one question. Dr. Lilis Dwi Sulistiani, DDS, oral surgery and maxillofacial consultant, as the first examiner, please put forward your question.
Thank you, Prof. Linda. Good afternoon, Dr. Sandy.
Good afternoon.
First, I would like to congratulate you on the achievement of reaching the end of the doctoral studies.
Thank you.
Congratulations, Dr. Sandy.
Thank you very much.
I have questions for you. You conducted the research on scan models from Caucasian cleft patients in the Radboud University Medical Center. How would the result of your research be applied or implemented to patients in Indonesia, considering that you are an Indonesian and work in Indonesia?
Thank you very much, Dr. Lilis. The question is, the Honorable Dr. Lilis Dwi Sulistiani, DDS, oral surgery and maxillofacial consultant. Your question is about the conducted of research on scan models from Caucasian patients in the cleft lip and palate craniofacial center, Radboud University Medical Center, and to what extent that my research can be used or applied to patients in Indonesia. Allow me to answer your question. This research evaluates the outcome after treatment has finished in 5-year period of time with the treatment protocols giving a good result that can be adapted to here in Indonesia. For instance, in this study, we can see that the Gosson score at the end of treatment does not exhibit score 5. In this center, the late heart palate repair in Nijmegen is performed together with the bone grafting procedure at around 9 to 11 years of age. Compared to other centers that use different approach at 3 years of age in the Netherlands, it was found that there are score of 4 or 5 in 45% of group of patients. So the result in the Nijmegen Cleft Center not only good because of the surgeon and orthodontist skill, but also all the team agreed the same protocol and all the members do the same protocol. So this cleft center approach should and could be easily developed in Indonesia as well. So it is recommended that this treatment protocol usage should only be based on scientific evidence and in agreement with all team members. Also, we can anticipate that the treatment stability in 5-year period of time, especially in the first 2 years after treatment, shows bigger decrease in the mandibular transverse dimensions and deterioration of interarch transverse dimensions. We conclude that it is better to have smaller Gosson score at the end of treatment, which means it shows better sagittal relationship, and patients can be informed that using combined retainers or fixed retainers and wholly retainers lifelong will help the stability of treatment outcome. And we can also inform the patient what to expect from the patient's age at the end of treatment, and also if the treatment or space closure of missing maxillary lateral incisor. Thank you, Dr. Lilis.
Thank you, Dr. Sandy. I'm satisfied with your answer.
Yeah, thank you, Dr. Lilis. Prof. Iwan Tovani, TDS, Oral Surgery and Maxillofacial Consultant, PhD. As the next examiner, please put forward your question.
Thank you, Professor Linda. And good afternoon, Dr. Sariesendy. Yeah.
Good afternoon, Prof. Iwan.
Yeah. First of all, I would like to give my congratulations for your dissertation progress, an interesting dissertation progress. But I have a question to you, Dr. Sariesendy. Yeah. This study focused on the mandibular arch, okay? And then because these patients are cleft-lid, complete non-syndromic unilateral cleft-lid, alveolus and palate, and in cleft side, usually there are agenesis maxillary lateral incisors, okay? Okay. There are agenesis maxillary lateral incisors. What is your opinion about this fundamental condition in maxilla? Okay. And then to be related to your research results in mandible. Okay. Okay. Okay, please, Dr. Sariesendy.
Thank you, Prof. Iwan. The Honorable Prof. Iwan Tovani, DDS Oral Surgery Maxillofacial Consultant. Allow me to answer your questions about what is the fundamental conditions in the maxilla and related to my results in the mandible. In my research, we know that a common feature in patients with a non-syndromic is of maxillary lateral incisor at the cleft side. And we found that if the space of a missing maxillary lateral was closed, the interarch deterioration in the first 2 years after treatment was larger compared to patients with space opening for a lateral incisor. This may be explained by the fact that closing the space narrows the maxillary dental arch, facilitating a cross-bite tendency, which will be reflected in deterioration of the MHP index. So whenever we close the space, you will make the upper arch smaller, and that has an effect in the interarch relationship. So therefore, it is not surprising to see that you have this effect when you close the space. And we have expected mandibular dental arch changes or adaptation to occlusion in the maxillary arch in patients with a non-syndromic CUCLAP, which is treatment. The present study shows that the mandibular arch does change after treatment has finished. It is shown by the transverse dimension and interarch relationship over the 5-year follow-up. However, in these samples, the mandibular intercanine distance did not change significantly. Because 85.3% of patients had a mandibular canine to canine retainer bonded to all anterior teeth. So MHB scores showed deterioration up to 4 points for the total score, which means there is an increase in the number of in the dentition. So the deterioration happened in the interarch relationship, yet it is shown that the mandibular arch showed only minor changes of the transverse dimensions. So we can conclude that the mandibular arch actually did not adapt completely to the changes in the maxillary arch dimensions, because if it did, the MHB scores would have remained the same. Thank you, Prof.
It's very good answer. Thank you, Professor Linda.
Yeah. The next examiner, Dr. Nia Ayu Ismaniati, DDS, MDSC Orthodontic Consultant. Please put forward your question.
Assalamualaikum warahmatullahi wabarakatuh. Thank you for the time. I would like to say congratulations to Dr. Sandy for that you have reached to this stage of your study, at the end of your study, and I'm proud of you because I know that you've been doing the research here and there, and then went to later. My question is, the result of your study showed significant decrease of the mandibular first and second premolar with p-value less than 0.05, while at the same time, the mandibular first and second molar distance showed significantly increased. So, in other words, your population research, the mandible transfer arch in the anterior part became compressed, while the posterior became expanded. Would you say the changes of the mandible is parallel to the changes that happen in the maxilla? And B, is there any evidence in the normal patient without CUCLP, the transfer changes after treatment would be different? Thank you, that's my question.
Thank you very much. The Honorable Dr. Nia Ayu Ismaniati, DDS, MDSC, orthodontic consultant. Allow me to answer your question. Your question is about the research, in my research, that we found that there is a decrease of transverse dimensions in the interpremolar distance and the increase of transverse dimensions of the intermolar distances. And then what we found is actually related to the changes in the maxillary arch. As we know, in untreated dentition, patients will show that the intercanine distance in the mandible and interpremolar distance in the mandible will decrease over time, but more in intercanine distance. And then, actually, while in adult patient, in adult untreated dentition, the interpremolar transverse dimension will show a decrease or stable up to adulthood, while in the intermolar transverse dimensions, in untreated dentition, there will be an increase of the score of the transverse dimensions. Therefore, we can conclude what happened in our research is the decrease of interpremolar distance of transverse dimensions showed that there's an adaptation for what happened in the maxillary arch. We know that maxillary arch will show a decrease in distance, always changing, prone to change because of the scar tissue happen, especially in the palatal area. So, of course, what we expect first, the mandibular arch will adapt, but what happened in our study is actually the mandibular transverse dimensions only adapt partly. It can be shown also that in interarch transverse dimension between maxillary arch and the mandibular arch, we can see that the MHB score is deteriorated. It is shown that the crossbite happens, especially in the interpremolar and intermolar distances. So we can conclude that even though there's a changes of continuing changes in the maxilla, it doesn't mean that the mandibular arch will adapt completely to the changes in the maxillary arch. Thank you, Dr. Nia.
Thank you, Dr. Sandy.
Thank you, Dr.
Dr. Benny Mulyono Sugiarto, DDS, MSc, Master of Orthodontics, PhD, Orthodontic Consultant. As the next examiner, please put forward your question.
Thank you very much, Prof. Linda. First of all, I'd like to congratulate my sister. I call her my sister since my undergraduate training, Dr. Sandy. Congratulations for achieving this stage. My question would be comprising in two parts. The first is, how would you adopt the results of your study into the orthodontic treatment protocol in general, especially in terms of the long-term retentions of travel patients, especially when you are applying the result of your study within the Indonesian populations, as what Dr. Lilies asked before. The second question would be, did you consider of comparing the changes of the arch dimensions in the mandible in your study compared to previous study, for example, the one that Dr. Nia conducted with the same populations as well in the maxilla? What about the differences in the significance of the arch dimension changes, as well as when you compare your mandibular arch dimension changes with previously reported studies like Little and Simon Little's group with the RCT recently with non-cleft patients. Is there any differences that may be implied with the differences with the two different conditions of the subjects? Thank you very much.
Thank you very much. The Honorable Dr. Benny Mulyono Sugiarto, DDS, MSc, Ort, RCS, PhD, Orthodontic Consultant. Allow me to answer your question. Your question is related to the protocols as we, an orthodontist, should have in order to treat our patients. And it is about, actually, we'll come to the retention phase. As we know that especially in 2 years after treatment in the patients with CUCLAP, the changes happen more than over the 5-year period. So we can conclude that actually in these samples, well, most of the patients were fixed retained, yet still show that the changes still happen. Then after that, we conclude it is better that we advise our patients with CUCLAP especially to wear not only the fixed retainer bonded canine to canine, but also combined with the Holy retainer. And of course, we know that the adaptation will always continue of all the changes in the maxillary arch. So we will advise also our patients to use the Holy retainer lifelong. So compared to our patient in orthodontic case without CUCLAP, actually, there's a research about retention that the difference between the part-time wearing of retainers and all-day retainers shown that there's no significant changes so far. So that is without the CUCLAP. So I think I would suggest our patient to use the retainers in patients with CUCLAP differently rather than with our patients without the CUCLAP. So in our patient without CUCLAP, they can wear part-time on using retainers. But here in our patients with CUCLAP, it is better to suggest, especially 2 years after treatment, that we use the lifelong retainers of Holy retainers combined with fixed retainers. Thank you, Dr. Ben.
Thank you very much, Dr. Sen.
Dr. Melissa Diatman, DDS, PhD, as the next examiner. Please forward your question.
Thank you, Professor Indawati. First of all, I would like to congratulate Dr. Sariesendy for completing her research and reaching the final step of her study. We are very proud of you. My question is related to the measurement of your research. Could you explain why you choose the Gosling yardstick index and the MHB index to evaluate the treatment results on the dental casts instead of other available in this with the same nature? And you also mentioned in this research that influencing factors of transversal dimensional changes in the mandibular arch could not be determined. Could you elaborate the reason why you found this phenomenon in your study?
Thank you very much. The Honorable Dr. Melissa Diatman, DDS, PhD. Allow me to answer your question. So in this research, we put the Gosling score at the end of treatment as one of our contributing factors because, as we know, the Gosling score or the Gosling yardstick has been the gold standard in evaluating the treatment outcome of the patients with CUCLAP. As we know, we need a very a good and skilled orthodontist or oral surgeon to be able to use this index. Why we use this as one of our contributing factors? It is because we know from this treatment outcome that the sagittal relationship of the patients will show whether it will need not only the regular treatment like orthodontic treatment, but also sometimes we should combine that with the orthodontic surgery. So that is why, as the gold standard, we prefer Gosling yardstick, the Gosling score, to be our one of contributing factors. And for the MHB index, it is the score that measure the transverse, the interarch transverse dimensions. And this index is user-friendly. So you don't need an expert to do it. You can teach someone and to be calibrated so that they can measure the same like the skilled person. And while in this research, we chose the MHB index because we want to show whether the mandible and the maxilla will have change in their interarch relationship. So it will enhance, it will point out that what we have in this research is not only the changes in the mandible, but what happens if we make the occlusion to the maxilla. So as conclusion, the MHB index is a good tool. And even though we actually tried to compare between the Gosling score, we want to correlate whether the Gosling score yardstick and the MHB index in these patients, whether does it show if the MHB index is low and the Gosling score will be low also. But actually in this sample, we may not be able to use it as we know we don't have the Gosling score with score number 5, which is really unfortunate at that time, because if we can do it, maybe we can correlate that and we can make conclusion that actually if the MHB index is good or low, which is showing if the MHB index is higher, which is showing that there's no cross bites, it is correlated with the Gosling yardstick with the low score, which is showing that the sagittal relationship is good. So in the end, we conclude that the Gosson score at the end of treatment is the good parameter for us to show that this patient will have better stability in the over 5-year period, because we can see in the MHB index that score is less deteriorated. Thank you very much, Dr. Melissa. And the second question is about the contributing factors is not relevant in the transverse dimensions. And for that questions, actually, when we have the statistic analysis, it is shown that actually the significance is less, and in some of our contributing factors, it doesn't show anything that we can conclude. So the pattern is actually not clear enough so that we can make any assumptions from that analysis. As we know, of course, the transverse dimension in the mandible, it is shown significant, even though the changes is actually only minimal, because it's so minimal, even it's only around less than 1 millimeter, then everything will show significant. That is why when we try to relate to the contributing factors, it doesn't show much, because what happened in the mandible actually only partly adaptation. So the decrease is actually, even though it is significant, but it is really minimum. So that is why when we want to try to make assumption from that analysis, it is shown that there's no clear pattern about the decrease in the transverse dimensions of the mandibular arch. Thank you very much, Dr.
Thank you very much, Dr. Sariesendy. I'm satisfied with the answer.
As the next examiner, Dr. Mete A.R. Kuipers, DDS, MSc, PhD. Please put forward your question.
Dear Dr. Sandy, I would first like to congratulate you for your work and for this massive book work you have made of it.
Thank you.
I have a question about one of the suggestions you do. As was earlier mentioned, you now study the Caucasian population, and you suggest that we should keep on collecting long-term results for cleft treatment, so we can also compare inter-center outcomes. And my question is, what do you think is, how would you see that in Indonesia, and how with which population would you like to compare, and what do you consider the most important data you can collect and keep to be able to compare?
Thank you very much. The Honorable Dr. Mete Annemarie Ronald Kuipers, DDS, MSc, PhD. Allow me to answer your questions. So the question is, which population will I take as our next research project? For example, enable to continue what we have to the future and to be applied in Indonesia. Actually, I will go to the outcome evaluation first, because as we know, here we have just made a consortium about the treatment protocol, and I hope it will be adapted quickly in the near future, because actually at the beginning, the treatment protocols are not the same. I really would like to have more research about comparing actually the treatment outcome with different centers in Indonesia, because at this moment they are still adapting to the new treatment protocols. And as we know, we don't have enough coverage from the national health insurance yet for the whole treatment of the patients with CUCLAP yet. And at least at this moment, we can have the evaluation of the treatment in Indonesia up to primary surgery. So that is what I want to explore about. And also, I would also to explore about the treatment outcome, not only based on what we have done, but I would really like to have the research about the evaluation from the patient side. As we know, patients are human beings. They are our friends. So it would be wiser if we consider more from their aspect. So in the near future, we should have more extensive research that giving more patient-oriented. For example, like we have in the ICHOM, and then we can have the modification in ICHOM Plus. And also there's a new research also in the HANQ. So all of that are the patient-reported outcome and also the patient-reported experience. So again, the evaluation of the treatment outcome, that still not here yet, especially in the long term, especially in the cleft palates, in adult patients with CUCLAP, and then we don't have also the evaluation, the standardized evaluations of the patient-oriented or outcome. So I think in the near future, we should have that kind of treatment evaluation here especially. Thank you, Dr. Mehta.
Okay, I'm satisfied with this answer.
Yeah, thank you. Dr. Edwin M. Ongkosuwito, DDS PhD, as the next examiner, please put forward your question.
Thank you, and thank you very much for attending this. And I'm very happy that we could do this research together, and also with the result, this article in a very high publication. I have more or less two questions. One of the questions is about, you described in the discussion and also reported that you found that the post-treatment changes were less if patients had a lower Gosling score at the end of treatment, which stands for better sagittal jaw relationship. Part of my question is, could this also be that they started out with a lower Gosling score and that they therefore had a better sagittal jaw relationship and perhaps a better MIB score? And second, if you are talking about start of evaluation, how would you do that in Indonesia? In the Netherlands, for example, we have this Dutch registry, and there we register every cleft in an anatomical way. If you have to choose, would that be one of the things that you would try to set up to get a good research also from a patient perspective, so that you can divide them in the correct phenotype of cleft lip and palate, since you described this research the complete unilateral cleft lip and palate. And from that perspective, you also write that this is different compared to other clefts.
Thank you. Thank you very much, Dr. Edwin. So glad to have you here. The Honorable Dr. Edwin Matthews Angkosweto, DDS PhD, allow me to answer your questions about what we have in our samples, that the patients have lower Gosselin score at the end of treatment. And as we know, most of the patients display the score of 1 and 2 and without the score 5. So actually in this center, that the Gosselin yardstick, this Gosselin score at the end of treatment exhibit only good, showing good sagittal relationship from the beginning, at the end of treatment. So when we observe for over 5-year period, we can see that with the better jaw, the better sagittal jaw relationship, actually the treatment outcome more stable, and it can be shown by the MHB index, the MHB score, that is less deteriorated. So yes, in this sample, most of it has a good or lower Gosselin score at the end of treatment. And I'm sorry for the second questions. It's about what would we have to have the evaluation in Indonesia, and then which setup that we would like to have, at least. Okay. Thank you very much. For the setup, as we know, we should have the minimum set of medical record. But here, we would really appreciate if the patient can have at least photographs that shown during their treatment, not only after primary surgery, but also can be after secondary bone graft, and then after the treatment of orthodontics, or maybe after the orthodontic surgery, and after the whole treatment has completed. But so far, we have in here, we don't have the patients like, at least in good medical record, that have all the record about starting from birth on until 5 years after treatment. So what I conclude from that research, I would really love to have that kind of minimum set, like, at least the study model, and we can have a good medical record, all complete with everything about family history and so on. And then we can have all the record about the primary surgery with the study model, and also, of course, completed with the photographs and the radiographs. At least we can have the panorama and cephalometry radiographs. But at this moment, maybe we should make a minimum of the medical record that we can have as our data for our next project of research. Thank you, Dr. Edwin.
Thank you. I'm satisfied with the question, and I think it would be a great idea to set up a register, so that is a register at birth without any records, because that is quite feasible. Thank you very much.
Thank you very much. Yeah, thank you, Dr. Edwin and Prof. Anna Marie Kuipers, Jahman, DDS, PhD, FDS, RCS. Please put forward your question.
Thank you very much, Prof. Linda. First, I would like to congratulate the candidate with the results. And it's a pleasure for me to have the opportunity to ask a question also, as your co-promoter. And I have a more global question about your research. You found that at a younger age, at the end of treatment, when there was space closure for the maxillary lateral incisor and with a higher Gosland score, that has a negative influence on the long-term results. And then in the discussion, you give some recommendations that focus on orthodontic interventions, for example, lifelong retainers like Holly. But shouldn't we think in a different way? I would like to say, I would like to prevent all these negative effects from the beginning. So my question is, where should we start? With your proposal, you start at the end, but I think we should start much earlier. Could you reflect on that, please?
Thank you very much, my beloved Prof. Anna Marie. The Honorable Professor Anna Marie Kuipers Jatman, DDS, PhD, FD, SR, CS, and allow me to answer your question. How can we prevent this negative effect? Where should we start? I think, yes, I agree with you. We should start from the very beginning. We should start from the prevention of the collapse itself. So we can prevent from the birth by making the pregnant woman taking daily dose of folic acid during the first stage of pregnancy. It can prevent not only orofacial collapse, but also spine bifida, where the effect is more than collapse actually, which is only partial. And we should focus on intake in the general health nutrition with a lot of folic acid during pregnancy. And we should not forget that smoking, both parents are not allowed, and we should avoid alcohol intake. Also, at the surgical intervention stage, we know that surgeons play important role of their skills, that they at least must have at least minimum 40 surgery procedures each year to be skillful. So, and the procedure should be done using the most familiar technique, and it will be better if the surgeons do in the collapse centers. And don't forget the involvement of orthodontists from the beginning of treatment in collapse. We also know that surgical results should be done by preventing a lot of scar tissue, especially the palate, because less scar tissue will give better and more stable treatment outcome. Again, the surgeon's skill will play an important role on this matter, so it would be suggested to find new techniques of surgery that could give result with less scar tissue, maybe for instance, like separating and leaves the periosteum, which is really hard. And then we can also anticipate some breakthrough of tissue engineering, such as the scar-free wound healing, the novel tissue cultures of grafting and so forth. So Of course, these new developments may well need RCTs to validate their worth. And then we can also use some approach of matrix, regenerative matrix with growth factors and cell types that induce the regeneration rather than repairment. So it will need a comprehensive review of engineering approach for scar-free wound healing with the emphasis of the pro-regenerative biomaterials to minimize scar formation in skin injuries. Also, there's also a new perspective from the medicine that there's like pirfenidone, nintedanib, galunisertib. Those are the medicine that is for the regenerative. It will reduce the expression of collagen and so on. So it has proven that they have anti-fibrotic efficacy. Therefore, it is a good candidate, ideal candidate for further study in context of cleft repair. Also, the mesenchymal stem cell that can be easily accessed from the umbilical cord tissue and blood for regeneration of skin and muscle tissue. It can really good because they can differentiate into the required cell types and secret regenerative factors. So the scar tissue is actually can be healed. Thank you very much, Prof. Anna Marie.
Thank you very much, Dr. Sari. I'm satisfied with your answer. You have shown that there is still a lot of research to be done in the field of cleft lip and palate. Thank you very much, and I will give the floor back to the chairperson.
Thank you. Time has elapsed. The open doctorate thesis defense is finished.
The open doctorate thesis defense is finished. Allow us to conduct a closed meeting to evaluate the candidate, and this meeting is adjourned.
The Board of Examiners will hold a closed meeting. Distinguished, please wait for a moment as the meeting will be held for 15 until 30 minutes. Distinguished guests, this open doctoral thesis defense is now reopened.
This open doctoral thesis defense is now reopened. Doctorate candidate Sariesendy, DDS, orthodontic consultant. We have studied the thesis that you submitted to us and also consider your defense of the questions and objections from our side. The team of promoter, chaired by Professor Dr. Beni S. Latif, DDS, oral surgery and maxillofacial consultant, has conveyed information regarding your skill development, and the head of the study program has reported the result of the research proposal examination, research result seminar, closed doctorate thesis defense, and publications. Based on all of those above, the Board of Examiners has decided to appoint Sariesendy, DDS, orthodontic consultant, as a doctor in dentistry science study program with judiciary cum laude with the GPA 3.93.
Speech by promoter.
Alhamdulillah, hari ini kepada Dr. Sandy, spesial sama kita yang menyelesaikan yang terbuka yang ngomong rasanya sulit mengungkapkan perasaan saya kata-kata harus perhatian dalam meraih kebenaran berpolitik. Perjalanan dan perjuangan yang cukup panjang, terutama lagi adanya masa pandemi, sehingga banyak rintangan dan tantangan yang harus dihadapi oleh Dr. Sariesendy selama menjalani proses. Akan tetapi, semuanya dapat dilalui dengan penuh semangat dan optimisme yang tinggi sehingga dapat selesai. Pada disertasi Dr. Sariesendy dengan judul Post-Treatment Changes in Mandibular Arch in Patient with Unilateral Cavity Impediment, the study in the Lip and Palate Center, Craniofacial Center, Lagos Medical University Center, mengangkat tema yang belum ada di dalam penelitian yang saat ini, memperhatikan ketemuan yang terjadi pasca perawatan komprehensif. Penelitian ini adalah satu standar penelitian protokol untuk recommendation para drug center seperti di Indonesia yang memberikan hasil yang baik. Penelitian juga mengevaluasi untuk transversal mandibular keluar, transversal antar pencernaan, inisial sindromik hearing atau pasca perawatan. Dengan hasil perawatan ini diharapkan perubahan tidak diketahui orang dan tidak terhasil dengan program. Terwujud disertasi ini merupakan rangkaian penelitian yang dilakukan secara sistematis, bertahap, dengan tingkatan arahan para promotor dan penguji. Untuk itu saya selalu bersyukur dan terima kasih atas bimbingan, kontribusi dan arahan masukan kepada dokter medis Amerika Serikat, promotor dan saya akan berbahasa Inggris sehingga saya bisa bicara dengan Professor Mari, Dr. and Professor Mari, thank you very much to invite Dr. Sariesendy using the data of the University Medical Center to be as a co-study of Dr. Sariesendy and guide and put to Dr. Sariesendy PhD. Not only that, the collaboration as a role of orthodontists in centralized comprehensive treatment of orofacial cleft in the UI. Also, I would like to thank you to Dr. Mete, Dr. Edwin Ongko Sobito as a board examiner, reinforcing in Dr. Sariesendy until he achieved his aim. And so also, I would like to thank you to Dr. Ewal Bronkhos, his tremendous assistant in statistics. Kepada semua pemuji yang diketahui oleh Dr. Lilis Dwi Sulistiani, Profesor Iwan Topani, Dr. Nia Ayu Ismianiati, Dr. Beni Sugiarto, Mas Ortodontis, Dr. Medisa Adiatman, Dr. Mete Kuipers, Dr. Edwin Songsuyo, terima kasih banyak. Juga tak lupa saya ucapkan terima kasih kepada Ibu Dekan, Profesor Linda Kusdani yang telah hadir pada hari ini untuk memimpin ujian terbuka. Let me mention several names that attend this open examination of Dr. Sariesendy. First is I would like to thank you to Professor Nakamura, Norifumi Nakamura from Kagoshima University of Japan, to Professor Talka from University of Erlangga, Dr. Cendrawasi from University of Gajah Mada, Dr. Safruddin Haq, and specialist neurosurgeon, Dr. Eni, specialist orthodontist from Harapan Kita Cleft Center. Terlaksana dan suksesnya sidang terbuka pada hari ini merupakan hasil para pimpinan FKG UI serta hasil kerjasama semua panitia penyelenggara hingga acara ini dapat berjalan dengan lancar. Untuk itu saya ucapkan banyak terima kasih atas kerjasama dan bantuan dan kerjasamanya. Keberhasilan Dr. Sariesendy dalam menempuh pendidikan ini tidak luput dari dukungan keluarga. Untuk itu saya ucapkan terima kasih dan selamat kepada Bapak Insinyur Haji Subagio Hatip Darussa dan almarhumah Ibu Ngarain Umar serta Ibu Syarifah Luksa SE sebagai orang tua Dr. Sariesendy atas keberhasilan dalam mencapai kepada suami Dr. Sariesendy, Bapak Raden Muhammad Muhammad Adam Maulana, serta kedua putra putrinya Muhammad Rafiq Asyaba, Sofia Wardah yang selalu menyemangati mamanya dan mendukung dalam perjalanan menempuh pendidikan itu. Sebagai akhir kata, saya ucapkan wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Dr. Sariesendy, DDS, orthodontic consultant, is the second doctoral graduate in 2022 and the 125th doctoral graduate from Faculty of Dentistry, Universitas Indonesia. On this occasion, we would like to give our gratitude to Vice Rector of Research Faculty from Universitas Indonesia, Vice Dean, Faculty of Dentistry, Universitas Indonesia, Head and members of Professor Council, Faculty of Dentistry, Universitas Indonesia, Head and members of Academic Senate, Faculty of Dentistry, Universitas Indonesia, managers, head of department, and head of unit, Faculty of Dentistry, Universitas Indonesia, Director of Faculty of Dentistry, Universitas Indonesia Dental Hospital,
Dr. Insinyur Ewald M. Bronkhorst, Radboud Institute for Health Sciences, Department of Dentistry, Radboud University Medical Center, Nijmegen, the Netherlands. Professor Norifumi Nakamura, DDS, PhD, from Department of Oral Maxillofacial Surgery, Kagoshima University, Japan. Professor Soichi Miyawaki, DDS, PhD, from Department of Orthodontics, Kagoshima University, Japan. Dr. M. Safruddin Haq, DDS, Oral Surgery and Maxillofacial, from Cleft Labiopalacesis Center, Harapan Kita Hospital, Jakarta. Eni Tiasandarwati, DDS, Orthodontic Consultant, from Cleft Labiopalacesis Center, Harapan Kita Hospital, Jakarta. Professor Talka Hamid, DDS, Orthodontic Consultant, PhD, from Faculty of Dental Medicine, Universitas Airlangga, Surabaya. Dr. Cendrawasih, DDS, Master of Health, Orthodontic Consultant, from Department of Orthodontics, Faculty of Dentistry, Universitas Gadjah Mada, Yogyakarta. Late Dr. Abdul Latif, DDS, Oral Surgeon and Maxillofacial Consultant, from Department of Oral Maxillofacial Surgery, Faculty of Dentistry, Universitas Indonesia. And our gratitude to the Board of Examiners, Promoter, Professor Dr. Benny S. Latif, DDS, Oral Surgery and Maxillofacial Consultant. Co-promoter, Professor Anne-Marie Kuipers Jahman, DDS, PhD. Chair of Board of Examiners, Dr. Lilis Dwi Sulistiani, DDS, and Oral Surgery and Maxillofacial Consultant. Members, Professor Iwan Tovani, DDS, Oral Surgery and Maxillofacial Consultant, PhD. Dr. Nia Ayu Ismaniati, DDS, MDSC, Orthodontic Consultant. Dr. Benny Mulyono, S, DDS, MSc, Master of Orthodontics, PhD, Orthodontic Consultant. Dr. Melissa Adiatman, DDS, PhD. Dr. Mete R. Kuipers, DDS, MSc, PhD. Dr. Edwin M. Ongko Suwito, DDS, PhD. And also to the family, husband, Emma Muhammad Adang Maulana, and Father Insinyur Sumardi Hatip Darussam, and son Muhammad Hafiz Aziz Syafa, brother and sister Cesar Gri Sumardi, Hasilah Sabrina, and then Saki Sumardi. Dan juga para undangan lainnya yang tidak dapat saya sebutkan satu persatu, namun tidak mengurangi rasa hormat kami. This open doctorate thesis defense has been successfully conducted, and I hereby close this examination for the open doctorate thesis defense of the doctoral program at the Universitas Indonesia.
To the Board of Examiners, may we ask for taking picture with Dr. Sariesendy, DDS, Orthodontic Consultant.
Agak miring mesti. Ya. Dokter Mele, awas dok.
Thank you. That concludes the open doctorate thesis defense of Dr. Sariesendy, DDS, orthodontic consultant. We all the committee would like to thank and apologize for all the shortcomings, and we congratulate Dr. Sariesendy, DDS, orthodontic consultant and family. Thank you. Nggak salaman berarti.
Ya, tidak ada salaman.
Ya, makasih dok.
Selamat Dr. Sariesendy.
Bentar, selamat ya Dokter Sandi. Selamat Wawa.
Selamat Wawa.
Selamat Tante.
Selamat Tante.
Selamat Kak Sandy.
Selamat.
Omedeto gozaimasu.
Selamat Tante Sandy.
Selamat Dokter Sandy. Alhamdulillah.
Selamat Dokter Sandy. Dari Tantan Jogja.
Ada lagi yang mau disampaikan?
Thank you to Charlotte dan Lukas.
Selamat ya Sandy.
Thank you to Mr. Hans.
Selamat.
Congratulations, Sandy. I'm very happy for you.
Bentar, belum pasang kamera.
Excellent, Dr. Sandy. Congratulations.
Dokter Tantan.
Halo. Selamat ya dok.
Ini Papi Sumarti.
Maaf ya.
Mbak Yani nggak sayang?
Selamat untuk Sandy.
Jadi selamat ya.
Selamat dokter. Selamat ya dokter Sandy. Semoga berkah.
Terima kasih dokter Eka. Selamat dokter Sandy.
Bisa dicapai oleh
Bisa.
Selamat ya.
Selamat ya Dokter Sandy.
Ayani, Rizka.
Baik, terima kasih Pak.
Selamat Sen.
Congratulations, dokter Sandy, selamat.
Papi salam hormat dari Surabaya.
Sandy, selamat ya Sandy. Selamat. Ya, selamat. Irsyad.
Selamat Tante.
Hafiz mana?
Nyau.
Om Gary. Pak Sandy, selamat. Kasih kiss maunya. Bukti, Prof Endang, makasih ya Prof Endang.
Berkah Dokter Sandy dan keluarga, selamat.
Terima kasih Mbak Nada.
Alhamdulillah.
Di sini kelihatan.
Selamat dok, selamat ya dok.
Selamat. Selamat dari KL.
Di mana?
Selamat ya, Dokter Sandy dari Singapura.
Sandy, selamat ya dari Lotte. Terima kasih Dokter Dewi. See you in